The broadcast is now starting. All attendees are in listen-only mode.
Welcome to the American Brain Tumor Association's free educational webinar series. Thank you for participating in today's webinar. Today's webinar has been graciously sponsored by Accuray and is on whole brain radiation versus stereotactic radiosurgery. The webinar will be presented by Dr. Stephen Chang. Please note that all lines during our webinar today are muted. If you have a question you would like to ask, type and submit it using the question box in the control panel on the right-hand side of your screen. Dr. Chang will answer questions at the end of his presentation. In the next few days, you will receive an email asking you to take a brief survey to evaluate the webinar. Please take a few minutes to share your feedback, which is important to us as we plan for future webinars. Today's webinar is being recorded. The recording will post to the ABTA's website on the Anytime Learning page shortly. Registered participants will receive the webinar recording link and a follow-up message tomorrow. Let's pause for a moment so we can begin our webinar recording here. The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our webinar today will discuss whole brain radiation versus stereotactic radiosurgery. My name is Christine Daly, Program Manager here at the American Brain Tumor Association. I'm delighted to introduce our speaker today, Dr. Stephen Chang. Dr. Chang is a professor and vice chairman of strategic development and innovation in the Department of Neurosurgery at Stanford. He is also the inaugural holder of the Robert C. and Jeanette Powell Professorship in the Neurosciences at Stanford University School of Medicine. Dr. Chang has a national and international reputation as an expert in both microsurgery and radiosurgery for treatment of brain, spine, and skull-based tumors, and is the co-director of the Surgical Neuro-Oncology Program. His radiosurgery practice focuses on the use of the CyberKnife to treat neoplasms of the brain and spine. He was instrumental in the rapid growth of the Stanford CyberKnife Radiosurgery Program and is currently co-director of this program. Thank you for joining us, Dr. Chang. You may now begin your presentation.
Okay. Good morning, everybody. I'd like to thank the American Brain Tumor Association for this opportunity to speak on whole brain radiation and stereotactic radiosurgery. And I'm going to provide a broad overview of these two modalities, as well as the advantages and disadvantages of these two modalities, and be happy to answer any questions at the end of my presentation. So what is whole brain radiation therapy? I'd like to start with some definitions of what these two types of radiation are, because they can be confusing when patients hear the word radiation. It's kind of a very generalized term. So let's start with some definitions. Whole brain radiation is a long-standing method of delivering radiation to cover the entire brain. And this type of radiation treatment has been around for 60 to 75 years. It is primarily used to treat brain metastases tumors because those are the type of tumors that will be dispersed through the entire brain. Whole brain radiation is not used to treat very localized tumors such as meningiomas or acoustic neuromas. And we'll discuss this in a little bit more detail. So how does whole brain radiation work? Whole brain radiation works by whole brain radiation works by giving small doses of radiation to the entire brain on a daily basis. So in this case, the patient would come into the medical center for anywhere from 2 to 6 weeks to receive radiation for their type of tumor. Whole brain radiation doesn't require any targeting accuracy. In essence, you're treating the entire head. So one question that often comes up is, how do the normal healthy brain tissue, how do the neurons in the brain tolerate this type of treatment. So in this case, what we're utilizing is the fact that normal healthy brain cells are better at repairing radiation damage than the tumor cells. So essentially, the normal healthy brain cells receive the same dose of radiation as the tumor, but then over the next 24-hour period between the first radiation dose and the second radiation dose, the normal healthy brain cells have a series of repair mechanisms that occur in each cell that correct the damage from the radiation. Now, the tumor cells also attempt to correct the damage from the radiation, but they're not as effective as the normal cells. So essentially, the normal brain cells are better able to tolerate this radiation, and the tumor cells are more sensitive to the radiation and therefore are more likely to be damaged by this type of radiation. So in terms of source of radiation, I have just a couple of slides on machine types. So you'll often hear the word linear accelerator. It's abbreviated LINAC. If you talk to radiation doctors, they might say, we're treating you on LINAC number 4 today. Linear accelerator is a machine that generates X-ray photons. X-rays are the same type of radiation that we use to do a mammogram or a chest X-ray, but in utilizing them to treat tumors, we use higher doses of these X-ray photons to destroy the tumors rather than just take pictures of them. So with the linear accelerator, electrons are accelerated down the machine and they strike a metal target. Typically it's a tungsten target, and this collision between electrons and the metal creates X-ray beams which are then targeted to the patient. This is a picture of a standard linear accelerator. The patient, you can see, is lying on the table. The machine itself can rotate around an axis on the wall. That's called the gantry rotation. And the table itself can rotate on the ground, which is called the turntable rotation. So this type of linear accelerator has been utilized for many, many decades. It's the actual the machine itself has not changed much over time. When should whole brain radiation be used? There are several instances in which this type of radiation is the preferred therapy. The first situation where we like to recommend whole brain radiation is when there are multiple brain tumors. And multiple, this is kind of a vague term because what constitutes multiple varies from center to center. But for example, if a patient showed up with 30 brain metastasis in their head, we would recommend whole brain radiation because of the sheer number of tumors that need to be treated. When you have that many tumors, it's not feasible or practical to either do surgery or to do focused radiosurgery to treat those type of tumors. The second incidence where whole brain radiation might be used is when there is a high suspicion that there are additional tumors in the brain that are not visible on the patient's current MRI scan. So what does this mean? This means that when we look at the MRI scan and identify the tumors, we are relying on the fact that the tumors are of a certain size or number of cells to make them visible on the MRI scan. By the time a tumor is visible on the MRI scan as a small a dot or a small image, it is tens of thousands of tumor cells. So if we look at a smaller number of tumor cells, let's say 1,000, 5,000 tumor cells that constitute a tumor, that particular tumor will be too small for us to see on the MRI scan. So it would be impossible to target those relatively invisible tumors with a focused radiation such as radiosurgery, but very easy to target those tumors with whole brain radiation because essentially whole brain radiation is covering the entire head, and therefore anything visible or not visible would be treated. Whole brain radiation is also used when the type of tumor that you are attempting to treat is very sensitive to radiation. So what does that mean? That means the tumor cells respond and die very quickly to doses of radiation. So breast cancer, breast metastasis to the brain, lung cancer, lung tumors that go to the brain are types of tumors that are very sensitive to radiation. So those type of tumors would be consideration for whole brain radiation. This is an example of a patient's MRI scan of a brain. It's a one representative slice. The brain is the gray material, and you can see this patient on just this one slice has a number of tumors that are shown in white. Some are larger than others, some are very tiny little white dots. But this is a patient where we would consider whole brain radiation just because of the sheer number of tumors present. Furthermore, when you see this many tumors, it's very likely that there are additional tumors that are too small to be seen by the MRI scan but are present in the brain. And so those would also be covered if this patient underwent whole brain radiation therapy. When should whole brain radiation not be used? Again, this is not set in stone, but these are just some guidelines. And in general, if there are just a few tumors, so let's say the patient shows up with 1 or 2 brain metastases to their brain on the MRI scan, we would not recommend whole brain radiation, and we would consider using a focused radiation in the form of radiosurgery. And the reason for this is that if there's just 1 or 2 tumors, it is difficult to make the argument that you should radiate the entire brain, all the healthy neurons of the brain, in attempts to treat just 1 or 2 tumors that are visible. So in this case, we would recommend to this patient that had 1 or 2 tumors to consider radiosurgery rather than whole brain radiation. Another situation in which whole brain radiation is typically not used are for tumors that are highly resistant to radiation. And so what does this mean? Just as I mentioned in the previous slide, that breast and lung cancer tumors are very sensitive to radiation, there are other tumor types, such as melanoma, that are highly resistant to radiation and take higher doses of radiation to kill. In these tumor pathology types, we typically like to treat these with focused stereotactic radiosurgery, in which we can deliver higher doses of radiation to those tumors. Patients who have had prior whole brain radiation, we usually do not recommend a second course of whole brain radiation. It's very rare that we would do that. And the reason for that is that, again, with whole brain radiation, the normal brain tissue has received a fairly substantial dose of radiation already in the past, and any additional radiation to that normal tissue may result in increasing levels of complications. And the last situation in which we typically don't start off with whole brain radiation is when the patient's MRI scan shows a large tumor causing mass effect. And what does this mean? This is an example of a large tumor causing mass effect. You can see the tumor as the large white mass, and then around the tumor you see a dark gray area, and the normal brain is shown as a lighter gray area. The dark gray area represents edema or swelling, or in this case, fluid in the brain tissue as a result of this large tumor pushing on the brain. So in this situation, we would advocate surgical resection first prior to any radiation being used. If you treated this patient with whole brain radiation, you might run into problems with worsening swelling around the tumor during the radiation treatment. So the advantages of whole brain radiation: all tumors in the brain, both visible on the MRI scan and non-visible on the MRI scan, will be treated. There's no chance of missing a small tumor that's below the resolution of the MRI scan. Whole brain radiation is an outpatient treatment, and even though it may be for several weeks, the patient typically comes in each day for their treatment and then leaves and goes back home. And whole brain radiation utilizes the linear accelerators that are very common among medical centers and can be even done typically at smaller facilities because these are common types of radiation machines. The disadvantages of whole brain radiation I wanted to cover in this slide here. The first disadvantage of whole brain radiation is that it may disrupt systemic treatment. So patients with cancer are often on chemotherapy treatments delivered by their medical oncologist. If a patient is undergoing whole brain radiation therapy, they often need to stop their chemotherapy treatments for at least the period of time that the patient is actually receiving radiation. So if a patient is receiving radiation for 3 weeks for their breast cancer tumor that has spread to their brain, we would have the medical oncologist stop any chemotherapy for that 3-week period of time. And this, as I said, can sometimes cause a disruption because the patient is receiving their chemotherapy because of their cancer disease. And so there is a lot of reluctance on the part of the patient and the oncologist in terms of withholding that treatment for a period of time. Whole brain radiation requires several weeks of treatment to deliver. It's typically a Monday through Friday, 5 treatments a week. And so if the patient requires 15 treatments, you're talking about 3 weeks of treatment to complete this course. Whole brain radiation has some side effects. Generally, there can be some fatigue, and this is something that starts during the later part of the course of radiation. It's not immediate, but toward the tail end of the radiation, this fatigue can kick in and can last for a number of weeks after the treatment is completed. It's generally self-limiting and resolves on its own. Whole brain radiation results in temporary hair loss, so the hair thins and falls out, often in clumps, and then takes some period of time to grow back. There can be some hearing loss that can occur with whole brain radiation, not immediately after treatment, but down the line, and that is because the hearing nerves in the region of the brain called the cochlea are very sensitive to radiation, and down the line after whole brain radiation treatment, a year or two later, patients may develop some decrease in hearing because of this. Balance problems can occur over time after whole brain radiation, and this is due to the fact that the cerebellum, the area of the brain that controls balance and coordination, also similar to the hearing region of the brain, can be sensitive to radiation. And finally, the most significant side effect of whole brain radiation that patients and physicians worry about is their cognitive ability, their memory, and their concentration. This is something that doesn't necessarily happen right away after whole brain radiation, but once a patient reaches 1 year or 2 years following whole brain radiation, a substantial percentage of these patients will exhibit memory and concentration difficulties. So it's a side effect that patients worry about because it can impact their quality of life. And to somewhat, it's a trade-off because we're attempting to kill the tumors in the brain now at the present, and we accept the fact that there could be a risk of cognitive issues down the line. So I want to now switch gears and talk about stereotactic radiosurgery. So the word stereotactic radiosurgery, what does that mean? Stereotactic is a word that means a method of delivering highly focused beams of radiation. So stereotactic uses a 3-dimensional coordinate system to deliver radiation extremely precisely to the brain or, frankly, any other part of the body. And radiosurgery is the word that combines the use of radiation with the precision of surgery. So radiosurgery, it's the generic term for a variety of machines that can deliver highly focused beams of radiation to their target. So I describe this to my patients as the beams are like laser beams. They're very precise. They target the tumor. They spare the normal brain tissue around the tumor. So it's a highly effective treatment for many brain tumors, and in many cases, it's an alternative for open surgery for these brain tumors. Radiosurgery was developed by, not by radiation physicians, it was developed by neurosurgeons. So it was conceptually thought of as a surgical procedure and an alternative to open surgery in the operating room. How does stereotactic radiosurgery work? So as mentioned previously, it's a method of delivering highly focused beams of radiation to the target. In this case, the target is the brain tumor. The accuracy is within 0.5 to 1 millimeter. So this is roughly 1/25th to 1/50th of an inch. So that's how precise the radiation can be delivered. And multiple beams of these precise radiation beams are targeted on the tumor to deliver the lethal dose to the tumor. Because of the precision of delivering this radiation, there is essentially minimal radiation to the surrounding normal healthy brain tissue. So in this case, the vast majority of the neurons, the healthy tissue in the brain, are spared from radiation when delivering this type of treatment. This is an example of a radiosurgical treatment plan. In the upper left image, you will see almost like a cartoon picture of the patient's head. You can see the two eyes and the nose and the mouth. And then you'll see a series of these light blue lines. Each of these lines is a beam of radiation. And you can see that they are coming into the head from many different angles. But they all seem to be pointing at a single spot in the patient's left forehead. And if you look at the other three images on the screen, those are MRI scans, and you can see the location of the brain tumor that is being delivered with this focused beam of radiation. If you look carefully, you can see a series of colored lines around the brain tumor, and that is the rapid fall off of radiation dose at the margin of the brain tumor. So you can see there is not really any substantial radiation dose going to the rest of the brain tissue. So when should radiosurgery be used in patients? Again, there's not a black and white set of rules here. The general concepts I'm going to discuss here, but there can be some variability from center to center. So the first instance where we would recommend or consider using stereotactic radiosurgery is when there are just one or a few tumors. As you recall, with whole brain radiation, we utilized it when there are many, many tumors. Radiosurgery can be utilized when there are just one or a few tumors. So in the previous slide that we looked at here, this patient just had one tumor. So rather than radiating the entire head and exposing the entire brain to radiation, focused radiation treatment makes sense. A second situation in which radiosurgery can be used is when the systemic chemotherapy treatments are not recommended to be interrupted. As you recall, with whole brain radiation, if it was delivered for, say, 3 weeks, we had to stop the chemotherapy treatments during those 3 weeks. In the course of radiosurgery, in which the radiation can be delivered in a single day instead of 3 weeks, it makes it much more feasible for the patient's oncologist to continue their treatments without any interruption. A third situation in which stereotactic radiosurgery should be used is when the tumor type is particularly resistant to radiation. And I used the example before of melanoma tumors. These tumors don't respond very well to the low doses of frequent radiation that are given with whole brain radiation therapy. They do respond very well to single high doses of radiation that are typically used with radiosurgery. So in this situation, with melanoma, we typically avoid whole brain radiation and do radiosurgery for these patients. And finally, there are some patients who come in with, let's say, 5 or 6 or 7 brain tumors, and they're kind of right in the gray zone between whole brain radiation and radiosurgery. And in some patients, they feel very strongly that they want to avoid the cognitive side effects of whole brain radiation, and so they want to go with radiosurgery, even though they know there may be tumors that are not quite visible yet on the MRI scan that may manifest themselves later. So when should radiosurgery not be used? Again, no extremely hard and fast rules here, but some general guidelines. The first is if the tumors are large and causing mass effect on the brain. And again, if you remember that slide I showed earlier of that large tumor with all that pressure on the brain, that again would not be a good candidate for either whole brain radiation or radiosurgery. That patient should have surgical resection of that tumor first before considering any form of radiation. In tumors that are highly symptomatic, so let's say you have a tumor that is pushing on the brain and it's impacting your balance or your speech function, radiosurgery often is not the best first-line treatment, because the goal of treatment is to take the pressure off the brain to alleviate the patient's symptoms, and hence surgery may be the preferred initial modality. Also, if there is significant swelling around the tumor prior to any treatment, we often rethink the role of radiosurgery. And the reason for this is that radiosurgery can actually make the swelling around the tumor temporarily worse before the tumor dies and the swelling gets better. So if a patient comes in with significant headaches or seizures related to swelling around a tumor and you do radiosurgery, you need to be prepared for that swelling to potentially get worse before it's going to get better. And then last, if there are many tumors, or if there is a concern that there are tumors that are not visible on the brain MRI scan, then we typically do not recommend a focused beam of radiation with radiosurgery. We do consider the whole brain radiation treatment. So here's an example of a situation where we might not want to treat with radiosurgery. So this is a patient's MRI scan. You can see the tumor in the top of the brain there. And on this sequence, this is the sequence with contrast that was injected into the IV when the patient was in the MRI scanner. So the tumor lights up with the contrast dye there. On this scan, you can't really appreciate any swelling around the tumor, but there are different MRI sequences that you can obtain. And so in this sequence, the large white area is actually swelling in normal brain around this particular tumor. So looking at this MRI scan, we would identify correctly that the patient does have a brain tumor, but we would also appreciate the fact that this tumor is causing a significant amount of brain swelling, and any type of radiation, whether it's whole brain or focused radiation, is likely to make that swelling worse. So if this patient already presents with symptoms such as severe headaches or cognitive problems or seizures from all this swelling, radiation is actually likely to make that worse, at least in the near term, before the tumor dies. This is another situation in which we would not recommend use of radiosurgery. This is a tumor that's causing significant mass effect on the brain. So in this situation, the tumor is located deep in the center of the brain, and it is pushing on the brainstem, which is adjacent to the tumor. So this person is likely to have significant problems with walking or with the strength in their arms or legs, because the tumor is essentially squashing the part of the brain that connects the brain and the spinal cord. So radiating this tumor is not likely to decompress the brain very quickly, and this patient should have surgery first. So I showed you some examples which we would not use radiosurgery, but what are the advantages of radiosurgery in patients in which you can use it? The examples are listed here, and I'll be happy to describe them in more detail. The first advantage of radiosurgery is that it minimizes radiation to normal brain tissue. And again, this is highly focused radiation. It can target the tumor with high precision and spare the normal brain tissue. On a actual tumor by tumor basis, radiosurgery has a higher chance of killing a tumor than whole brain radiation, because a single high dose of radiation typically works better at killing a tumor than many smaller doses of radiation. Radiosurgery is also an outpatient treatment and can be done fairly quickly. It does not interrupt the systemic chemotherapy cycles that we previously discussed. And unlike whole brain radiation, which is typically can be delivered once over the patient's lifetime or treatment course, radiosurgery can be repeated multiple times. So, for example, if a patient shows up with a single brain metastasis from their, let's say, lung cancer, and we treat it in July of 2018, and they develop two more tumors in December of 2018, we can repeat radiosurgery again, and we can repeat it again in 2019 if they were to develop additional tumors. So it's not uncommon for a patient undergoing radiosurgery with multiple brain tumors, let's say from their lung or breast cancer, to have many courses of radiosurgery over their lifetime. It's not uncommon to treat 25 or 30 tumors over the lifetime of the patient with radiosurgery. The primary advantage of radiosurgery over whole brain radiation is that it can be delivered in just one or just a few treatments. So let's say 1 or 2 days of treatment rather than 10, 15 or more days with whole brain radiation. And lastly, the radiosurgery generally avoids the cognitive side effects of whole brain radiation, so that memory issue, the forgetfulness that typically we see a year or two after whole brain radiation, is not something that we see with stereotactic radiosurgery. Here's an example of a patient that we treated at Stanford 20 years ago on the CyberKnife machine. So you can see in the slide to the left, the patient has a medium-sized tumor in their region of the brain called the temporal lobe. The tumor is shown by that purple arrow, and the edge of the tumor is outlined in white. This patient underwent stereotactic radiosurgery, and you can see 2 years later, it's almost impossible to see where that tumor was. The purple arrow on the right image is showing where the tumor was. So the tumor has shrunk dramatically and essentially disappeared on this patient's scan. So what are the disadvantages of radiosurgery? The first disadvantage is radiosurgery can only target tumors that you can actually see on the MRI scan. So we talked previously about small tumors that are below the resolution of the MRI scan. Those tumors would not be seen on the MRI scan and therefore could not be targeted with radiosurgery and therefore would be missed. Now, typically after you do radiosurgery, you obtain periodic brain MRI scans on the patient, let's say every 3 months or so. And if there was a tumor that was not visible and on the MRI scan at the present day, it may be visible 3 months from now, in which case then you could treat it with radiosurgery at that point. Another disadvantage of radiosurgery that we already discussed is that it can make swelling around the tumor temporarily worse, and this can increase symptoms. So if a patient has significant swelling in the brain around the tumor that's causing some arm or leg weakness and the patient underwent radiosurgery, you would need to prepare that patient for the consideration of at least that weakness getting worse for the next few months before it would get better as the tumor dies. And the other disadvantage of radiosurgery is that these tend to be more complex machines than the standard radiation machines, and not all facilities have these higher level radiosurgery machines. So it may mean that you may need to travel a further distance to receive this treatment than you would for whole brain radiation. So there are a number of radiosurgery machines. I wanted to just explain them briefly here. We talked about a LINAC or linear accelerator as a type of machine to deliver whole brain radiation. There are some advanced linear accelerators that do radiosurgery. The type that we utilize at our institution at Stanford is called the CyberKnife, and cyber meaning computer and knife being again a surgical tool. So it's a way to deliver focused radiation to tumors. It's made by a company named Accelerator, which is based in Sunnyvale, California. Varian is a large medical device company that makes radiation machines. They're also based in the San Francisco Bay Area. They make machines called True Beams and Trilogy machines. We also have those here at Stanford, and those can be used to deliver radiosurgery in patients. BrainLab is another company that makes a machine that delivers can be used to deliver radiosurgery. So those are all linear accelerator machines that use X-ray photons to treat the tumors. Another popular radiosurgery machine is called the Gamma Knife. This was developed back in the 1960s, so it's been around for a while. It uses radioactive cobalt to generate gamma rays to deliver the radiation dose. And finally, proton beam is a form of radiation that can be used to treat brain tumors. And you sometimes will hear about proton beam center. There are a number of these that are across the U.S. right now, and they can be used to do radiosurgery as well. So all of these types of machines, the linear accelerator, the gamma knife, and the proton beams, all produce a dose of radiation to kill the tumor. To some extent, the source of the radiation is less important than the dose, and what the brain tumor sees is just a specific dose of radiation. The brain tumor doesn't know the source of the radiation or the type of machine that is used to deliver that radiation. So here's what we covered. Gamma knife uses gamma photons, linear accelerators use X-ray photons, and the proton beam uses accelerated protons. Again, all deliver the radiation to the tumors, and the tumor doesn't know the source of the radiation. It just sees a specific radiation dose. Similar to whole brain radiation, when you do radiosurgery, the method is that electrons hit a metal target, and this collision creates X-ray beams which can be focused to target the patient. So here's a little schematic here. This is only physics slide I'm going to show, so don't worry about the complexity of this. But essentially, X-ray beam is an electron beam is delivered down this long tube. It strikes a metal plate here. It generates the X-ray photons, which is that blue squiggly line there, which is then delivered to the patient. So with a gamma knife, it uses radioactive cobalt as the source of radiation, and this radiation source is like any other radioactive material, is always on and is kept behind a lead shield when not being utilized, and during treatment, small openings in the lead shield are opened, and this allows the radiation to come out and treat the patient. And proton beams accelerate proton particles to very high speeds, and the patient is treated on a treatment table by these high-speed protons that are delivered at various different angles. So I want to show a couple of slides on the CyberKnife because this is the machine that I'm familiar with. It's a lightweight LINAC. It delivers beams of radiation by moving around the patient. And this is what a CyberKnife machine looks like. Essentially, the linear accelerator is mounted onto a robotic arm that moves around the patient. This is a cartoon of what a CyberKnife treatment room looks like. The flat surface is where the patient lies on the table, and there you can see two cameras in the ceiling taking images of the patient during the treatment. So I want to conclude with talking about situations where we would combine different treatment types. We've talked about whole brain radiation as a treatment modality. We've talked about stereotactic radiosurgery as a treatment modality, but it's not uncommon for us to combine treatments using these two modalities as well as surgery. So here's a situation where we might combine the two treatments. Let's say a patient shows up with an MRI scan of their brain that shows 30 different or 40 different brain tumors, we would recommend that patient start off with whole brain radiation therapy. Let's say the patient received that treatment and their next MRI scan 3 months later shows that of the 30 tumors, 28 look like they're shrinking, but 2 are still expanding. 2 look like they're still alive. You could then use focused radiosurgery to finish off those 2 remaining tumors that look like they're still viable after treatment. So another situation is, let's say a patient comes in, they have just 1 or 2 tumors, and you do radiosurgery on them and kill those tumors. But let's say their disease progresses over time, and the following year they now show up with an MRI scan that shows many, many tumors. At that point, you can add the whole brain radiation therapy to treat those multiple tumors. And then I mentioned there's situations where we would combine whole brain radiation and or radiosurgery with conventional surgery in the operating room. The first example would be a single large tumor and many small tumors. So this patient, let's say, has 5 or 6, or let's say 20 tumors. One is very large and the other rest of the tumors are tiny. It may make sense to do surgery to remove the large tumor first, and then use whole brain radiation to treat the brain, to treat all the multiple smaller tumors. Another situation where you would combine, in this case, radiosurgery and surgery is, let's say the patient shows up with just 2 tumors. One is large and causing swelling and clinical symptoms. The other is small on the other side of the brain, not causing any problems at all. You might recommend surgery to remove the large tumor to alleviate the patient's clinical symptoms, and then radiosurgery to treat the small tumor that's on the other side of the brain. So to summarize, I want to explain today, and hopefully I did, that whole brain radiation and radiosurgery are both tools that we use to treat brain tumors. They each have their advantages and disadvantages, and it's not a whole brain radiation therapy versus radiosurgery argument. It's that whole brain radiation and radiosurgery are both tools that we have in our toolbox to treat brain tumors. The optimal use and timing of whole brain radiation therapy and radiosurgery is individualized for each patient. As I mentioned, these guidelines that I covered today are not set in stone. They're very individualized from patient to patient. And that is the reason for patients to undergo specific formal evaluations in clinic prior to determining course of radiation treatments. And last is that whole brain radiation and radiosurgery are just one of the key modalities in the treatments of patients with cancer, along with surgery and chemotherapy. And again, it's not a radiation versus surgery argument. And what we like to do is consider all of these options for patients and come up with the best option for each individual patient, even if it means combining different types of treatment. So obviously, it's not just me doing this type of work at our institution. There's a whole list of individuals, and they're shown here, including other neurosurgeons, radiation oncologists, physicists, as well as radiation therapists and schedulers. I'd like to thank you for your time and attention today, and I would be happy to answer any questions that you may have.
Thank you, Dr. Chang. We will now take questions. If you have a question you would like to ask, please type and submit it using the question box in the webinar control panel on the right-hand side of your screen. Our first question for today is, can radiosurgery be used again on the same tumor?
The question is, can radiosurgery be used again on the same tumor? The answer to that question is yes, it can. When delivering radiation to a tumor, there is never 100% guarantee that the tumor will die. The success rates are quite high, typically above 90 to 95% chance of killing tumors with radiosurgery. But in the off chance that the tumor continues to progress despite radiosurgery, you can do a second course of radiosurgery to the same tumor.
Okay, and the next question, and you may have touched on some of these already, Dr. Chang, but if you could just give us a quick kind of second overview. The next question is, why should whole brain radiation not be utilized if it's been used before?
So that's a good question. The question is, why can you not do a second course of whole brain radiation? And the answer to that is that the dose of radiation used for whole brain radiation is fairly close to the upper limit of what a normal brain can tolerate before we see high amounts of side effects. So if you were to deliver a second course of whole brain radiation, you would be essentially almost exceeding the normal brain tolerance to radiation. And so the side effects would be, first of all, highly likely to occur, and second of all, be highly significant in terms of their clinical significance. So a patient is likely to have a lot of deficits, for example, with the cognitive issues, with a second course of whole brain radiation.
Thank you. The next question, are the various types of SRS radiation, photon, gamma, X-ray, equally effective on all tumor types, or do some radiation types work better on specific tumors?
So the answer to that question, for the most part, is that the choice of the machine is less important in killing the radiation than the dose of the radiation utilized. Now, what does that mean? That means that in each of these machines, you can choose you can dial up or you can dial down the dose of the radiation. And the tumor only sees the dose of radiation that it's given. It doesn't see the source of the radiation. So when I explain this to my patients, I use the example of if the tumor is a egg in a boiling pot of water, what the egg sees is a certain temperature. It does not know on the other side of the pot if the source of the heat is a gas or electric stove. It just sees a certain temperature, 250 degrees Fahrenheit, for example. It doesn't know the source of the heat. And so similarly for the tumors, all they see is a certain dose of radiation given to them. They don't know if the radiation is coming from a gamma knife or a CyberKnife. And so therefore it's not the machine that's effective, it's really the choice of the radiation dose used.
Okay, and next question, do you have any recommendations for patients in helping them to manage the fatigue or any of the other side effects that they experience from the whole brain radiation?
So the question is managing side effects from whole brain radiation. The fatigue was brought up as one of the side effects. That is generally something that's self-limiting. It lasts for anywhere from a few weeks to a few months and just gets better over time. Generally, that doesn't require any medical intervention to resolve. In terms of the cognitive side effects, that can be difficult to manage because those tend to be gradual in onset and progressive over time, meaning that they are likely to worsen as time goes on, even though the radiation treatment was done, months or years ago. And this cognitive side effect can substantially impact quality of life. So people have tried various things. They've tried medications that maybe would essentially be a stimulant for the patient. But again, you're then adding medications to a list of possible other medications that the patients are on. So it's difficult to manage the cognitive side effects with medications. Generally, we try to recommend lifestyle modifications. So rather than trying to remember everything, keeping lists, keeping things, coming up with an organizational system, visual aids, kind of reminders. Those are situations where we would try to manage that.
Thank you, Dr. Chang. Next question is stereotactic radiosurgery approved for pediatric oncology patients?
Yes, it is.
Okay, and next one, is there any difference in the accuracy and effectiveness between proton beam and other forms of SRS, for example, gamma knife?
So that's a question that comes up commonly, that it's the challenge here is there's oftentimes not a lot of published data in the medical literature regarding accuracy of the machines. The machine vendors will often try to promote or cite targeting accuracy, but in the medical field, it needs to be kind of published in what we call a peer review evaluation. So there needs to be tests that need to be validated and reviewed by third-party reviewers for it to be considered a legitimate targeting accuracy. So with machines like Gamma Knife and CyberKnife, there have been published accuracy, around typically 0.5 to 0.6 millimeters, and so that's published data in machines that are used commonly. For machines like protons, there are that are used not just for radiosurgery but for other types of forms of radiation. There's not that kind of level of published literature.
Okay, thank you, Dr. Chang. That is all the time we have for today. Thank you all for joining us, and thanks once again to Dr. Chang for his wonderful webinar presentation. Besides our free educational webinars, ABTA has a variety of programs available to help connect patients and caregivers with information and resources to help support them in their brain tumor journey, as well as publications and resources for healthcare professionals. For more information, visit ABTA's website at www.abta.org or call the ABTA Care Line at 1-800-886-2282. Let's pause for just a moment to conclude our webinar recording.